You are sitting in the clinic with an adult patient who has non-alcoholic fatty liver disease, or NAFL. Let's call him Mark.
We all have a mark on our panel.
Right. And Mark is in his early 50s, and you know him well. He's actually done everything you've asked. I mean, he's dedicated the last 6 months to serious, rigorous lifestyle changes.
Which is incredibly hard to do.
Oh, absolutely. We're talking a comprehensive dietary overhaul. He's cutting out the refined sugars, cutting out the evening beers, and he's doing consistent daily exercise. Plus, he's managed to drop about 15 pounds.
That is a massive clinical win.
It is. So you pull up his latest lab results on the monitor, and you're fully expecting to see this huge biochemical victory to match all his hard work.
But the numbers are red.
Exactly. His ALT and AST are still sitting there in the red. They are persistently abnormal.
It's honestly one of the most common yet heaviest moments in primary care and hepatology clinics. You're looking at the chart, you're looking at Mark sitting on the exam table, and he is expecting good news.
Yeah, he wants the gold star.
Right. And the immediate clinical dilemma staring you in the face is just glaring. Does this persistent enzyme elevation mean it is time to escalate? Do you prescribe medications, or do you stay the course with lifestyle management alone?
It really feels like a clinical crossroads. And honestly, it's a bit of a letdown for both the patient and the clinician in that room. Mark has done the work. He's looking to you for validation. But the lack of clear biochemical improvement creates this massive cloud of uncertainty. You start second-guessing. You wonder, is it time to reach for a pharmacologic safety net?
And that is our exact mission today. We are going to cut through that clinical uncertainty. We're establishing a clear, evidence-backed framework for treating this specific subset of NAL patients.
The ones with persistent abnormal enzymes despite real lifestyle intervention.
Exactly. We need to clarify exactly when pharmacologic therapy is warranted, and perhaps more importantly, when it is absolutely not.
Okay, let's unpack this. Because our baseline instinct in this scenario, for I think the vast majority of clinicians, is to just keep emphasizing those lifestyle modifications.
Yeah.
You sit there, you validate Mark's 15-pound weight loss, and you encourage him to just keep going with the diet and the exercise. You hold off on the prescription pad.
And that instinct needs to be strongly validated.
Yeah.
Because it is fundamentally sound medical practice.
Why is that so crucial to remember?
To understand why, we really have to look at the underlying pathophysiology. Non-alcoholic fatty liver disease is primarily driven by insulin resistance and metabolic dysfunction.
Right. It's a systemic issue.
Exactly. When a patient is insulin resistant, you have unchecked lipolysis happening in the adipose tissue.
So the fat cells are just releasing lipids.
Yes. And that dumps a massive influx of free fatty acids directly into the liver.
Yeah.
The liver tries to compensate, right? It tries to package them into triglycerides.
But it can only handle so much.
Precisely. Eventually, the system just gets completely overwhelmed, and that leads to hepatic steatosis. The fat just accumulates.
So by pushing lifestyle, we aren't just giving, generic advice like eat better. We are actively targeting that specific metabolic bottleneck.
That is the trap a lot of us fall into. We think of diet and exercise as a soft intervention, like it's just general wellness.
Right, instead of actual medicine.
But it's actually a highly targeted metabolic therapy. A sustained caloric deficit and regular physical activity directly improve peripheral insulin sensitivity.
Which shuts off that faucet of fatty acids.
Exactly. It shuts down that excessive adipose lipolysis, and it actually reduces de novo lipogenesis within the liver itself.
So the liver stops making new fat.
Right. And furthermore, if we look at it from a strict do-no-harm standpoint, continuing to support dietary improvements in physical activity carries virtually no clinical risk.
Whereas initiating systemic medications
Always introduces potential adverse effects.
Always. I hear the logic, and the physiology makes perfect sense. But let's be real for a second. When a patient like Mark is staring at his patient portal on his phone.
Yeah, the dreaded portal message.
Exactly. And he's practically begging for a pill to fix the red numbers on his screen. Holding the line with, just keep eating your broccoli and walking, feels like a letdown. He wants action. So what is our definitive stance here?
The core recommendation, the absolute anchor for your clinical decision-making here, is that the default clinical posture must remain continuing lifestyle intervention without starting medications.
So we hold the line.
You hold the line. For adults with simple NAFL who still have abnormal liver enzymes after 6 months or more of lifestyle changes, you do not initiate pharmacologic therapy by default.
But if a patient is demanding a prescription because they hate seeing that elevated ALT, What is the actual clinical danger of just giving them something to lower the numbers?
Mhm.
Haven't the lifestyle interventions technically failed if the enzymes are still high? Aren't we ignoring a physiological warning sign?
What's fascinating here is persistent enzyme elevation alone does not necessarily indicate that the disease is actively progressing.
Really?
This is the crucial disconnect between the lab report and the actual histology of the liver.
Because we're so trained to react to the labs.
Exactly. We have been conditioned throughout all of our medical training to treat the abnormal lab value, to fix the red number on the screen.
Yeah, the reflex is so strong.
But in the context of simple NAFL, an isolated elevated ALT does not mean the liver is inevitably marching toward architectural failure or cirrhosis.
That is a very tough habit to break. I mean, we see high AST or ALT, and our brains immediately scream, hepatocellular damage, fix it right now.
It's a completely understandable reflex.
We want to throw vitamin E or pioglitazone at the problem just to make the numbers look better.
You'd think that would be the right move, but the data tells a very different story.
Right.
We have to rigorously differentiate between surrogate markers and hard clinical outcomes.
Okay, let's break that down.
Liver enzymes are surrogate markers. Even some imaging results act as surrogate markers. But the hard outcomes, the metrics that actually dictate a patient's lifespan and quality of life.
Like overall survival.
Exactly. Overall survival, preventing the progression to cirrhosis or preventing outright liver failure, those are entirely different endpoints.
So lowering the ALT doesn't automatically mean we're extending their life.
Correct.
Let's get specific about the medications then. Why aren't we using things like vitamin E or pioglitazone for a patient like Mark? Because we know they are used in liver disease. Hepatologists prescribe them.
Here is the problem with applying that logic to Mark. It ignores the vital distinction between simple NAFL and NASH, nonalcoholic steatohepatitis.
Which is the more severe inflammatory form.
Right. The major clinical trials that looked at vitamin E and pioglitazone, such as the PIVENUS trial, specifically targeted patients with NASH.
Ah, okay.
These were patients who already had biopsy-proven histological damage and fibrosis.
Mm-hmm.
In that specific higher-risk population, those drugs showed some histological improvement.
But Mark doesn't have NASH or advanced fibrosis. He just has simple NFL with elevated enzymes.
Precisely. And when you try to map the data from NASH trials onto a patient with simple NAFL, the risk-benefit ratio completely flips.
The math doesn't work anymore.
It doesn't. There's a massive evidence gap here. Medications have not been shown to improve hard clinical outcomes in NFL patients who just have persistent abnormal enzymes after lifestyle intervention.
So if we prescribe pioglitazone to Mark just to make his ALT look prettier on the lab report, what risks are we actually exposing him to?
Well, pioglitazone is thiazolidinedione.
Right.
It improves insulin sensitivity via PPAR gamma activation, which sounds great,
Sure.
but it notoriously causes fluid retention, atypical bone fractures in women, and significant weight gain through adipogenesis.
Weight gain.
Yeah.
So imagine telling Mark, who just worked his tail off for 6 months to lose 15 pounds, that the pill you gave him to lower a benign lab number is going to make him gain 10 pounds back.
It would completely destroy the therapeutic alliance. He would be furious, and rightfully so.
And what about vitamin E? Because it's just an antioxidant, right? Patients buy it over the counter all the time. It feels so safe.
High-dose vitamin E, and we're typically talking 800 IU daily use in these hepatic protocols, is not benign.
Really?
No. Long-term use has been associated with an increased risk of hemorrhagic stroke,
Wow.
and in some data sets, an increased risk of prostate cancer in men.
So you have to ask yourself, are you willing to expose Mark to a potential hemorrhagic stroke just to get his ALT from 75 down to 40?
Exactly. Especially when there is zero evidence that lowering that ALT in his specific case prevents cirrhosis or extends his life.
When you frame it like that, with the specific adverse effects right next to the lack of outcome data, the default posture of no medications makes total sense.
It becomes the only logical choice.
We are literally chasing a surrogate marker at the expense of systemic safety.
Exactly.
But medicine is never a rigid, one-size-fits-all endeavor. If the default is no medications, when do we actually pivot?
Because there are times when you must pivot.
Right. What are the specific clinical triggers that tell us it's time to abandon the lifestyle-only route and write a prescription or refer out?
You have to be highly vigilant for specific red flags that justify a deviation. The first and most critical trigger is any evidence of advanced fibrosis or cirrhosis.
Okay.
If the underlying architecture of the liver is significantly scarring, the wait-and-see lifestyle approach is no longer sufficient.
The stakes are too high at that point.
Way too high. The patient's risk profile has fundamentally shifted toward end-stage liver disease and hepatocellular carcinoma.
But wait, how do we practically identify that in the primary care clinic?
We use non-invasive tools.
Because we aren't biopsying every patient with a fatty liver. And if we rely on ALT and AST, which we just established are flawed surrogate markers, how do we actually know if Mark is developing advanced fibrosis?
We utilize non-invasive testing, specifically the FIB4 test.
The FE4.
This should be a reflex calculation in your clinic. Every time.
It's so easy to do.
It really is. The FIB4 uses the patient's age, their AST, their ALT, and their platelet count.
Things we already have on a standard metabolic panel and CBC.
Exactly. It is cheap, it uses labs you already ordered, and it is highly validated. If you calculate Mark's FE4 and the score is exceptionally low, say under 1.30, you have a very high negative predictive value.
Meaning you can trust that he doesn't have advanced fibrosis.
Yes. You can confidently tell him his liver is not severely scarred, which strongly reinforces the lifestyle-only approach.
It gives you both peace of mind. And if the FIB4 comes back high,
then you escalate to transient elastography, like a FibroScan, to actually quantify the liver stiffness.
to get a physical measurement of the scarring.
Exactly. If elastography confirms advanced fibrosis, that is your trigger. You immediately shift toward aggressive management and referral to hepatology.
That makes perfect sense. Now, what about the massive overlap with other metabolic conditions?
It's a huge factor.
Because a huge portion of these patients don't just have an isolated fatty liver. They have an entire metabolic syndrome happening simultaneously.
Right. This raises an important question. How do we manage the complex metabolic web these patients are caught in, particularly regarding type 2 diabetes?
Because those two go hand in hand constantly.
They do. Comorbid type 2 diabetes is a major catalyst for liver disease progression. If your patient has comorbid type 2 diabetes and shows clinical deterioration despite dedicated lifestyle efforts, tailored pharmacologic therapy becomes highly relevant.
So in that case, we're reaching for the prescription pad. But are we prescribing for the liver or for the diabetes?
You are targeting their overall metabolic risk, which in turn benefits the liver.
Okay, I see.
In a patient with T2D and NAFLD, you are likely looking at GLP-1 receptor agonists like semaglutide or tirzepatide,
Which are incredible for weight loss anyway.
or possibly pioglitazone, because those drugs have robust data for glycemic control and cardiovascular risk reduction, and they have the secondary benefit of reducing hepatic steatosis. But, and this is a critical distinction, you are prescribing them based on their established indications for diabetes and obesity management, not solely to treat an isolated elevated liver enzyme in a non-diabetic patient.
That distinction is incredibly helpful. It's about treating the systemic metabolic state. We're using the GLP-1 to fix the insulin resistance and drive weight loss, which naturally unburdens the liver as a byproduct.
Exactly. It's treating the root cause. This often requires close consultation with endocrinology to optimize their regimen too.
Right.
Another crucial trigger to monitor is the actual trajectory of those surrogate markers.
The trend over time?
Yes. If Mark's ALT doesn't just stay slightly elevated at 75, but actively worsens over time.
Like jumping to 150 or 200.
Yeah, exactly. If it spikes like that despite his dedicated lifestyle intervention, that trajectory change is a massive red flag.
Because it suggests something else is driving the inflammation, outside of just stable fatty liver.
Right. It requires immediate reassessment. You need to rule out competing etiologies.
Like what?
Autoimmune hepatitis, viral hepatitis, hemochromatosis. And you likely need to initiate a specialist referral at that point.
So the trend is your friend, or in this case, your warning system. We also have to address the human element in the exam room, though.
Always.
Let's go back to Mark. You've explained the FAPI4 score. You've explained that his risk of cirrhosis is low, and you've detailed the risks of vitamin E and pioglitazone.
You've done the whole educational piece.
But he is still incredibly anxious. He sits there and says, I hear you, doc, but I'm doing the work and my numbers are red. I really want to try a medication just to see if we can get these numbers down. I can't stand failing.
That is a very tough conversation.
How do you handle that without making him feel abandoned or ignored?
That leads to a critical shared decision-making conversation. You do not want to be paternalistic and simply say no.
Right, that just breeds resentment.
You have to thoroughly and honestly lay out the uncertain risks and benefits we just discussed. You frame it not as denying him therapy, but as protecting him from unnecessary harm.
So you walk him through the lack of hard outcome data and the real risks of polypharmacy. The stroke risk, the weight gain.
Yes, you document that extensively. But If, after that comprehensive discussion, the patient still strongly prefers to attempt pharmacologic therapy to lower the enzymes, it requires a collaborative approach.
What does that look like practically?
You can proceed with a time-limited trial of a relatively benign agent, but it must be followed by extremely close clinical monitoring.
So you don't just write a year-long script and say, see you later.
Absolutely not.
Yeah.
And you must establish clear stopping rules from day one if there is no improvement or if adverse effects emerge.
Here's where it gets really interesting. Because establishing a robust clinical framework isn't just about knowing exactly what to do and when to pivot. It's equally about knowing what not to do.
The clinical pitfalls.
Exactly. We've touched on some of these, but what are the absolute clinical pitfalls that clinicians need to aggressively avoid in this space?
The biggest pitfall is how we define success and failure in the clinic. We must strictly avoid using liver enzyme normalization as the sole marker of treatment success.
Because, as we established earlier, ALT and AST naturally fluctuate anyway.
They do.
If Mark has a really hard workout the day before his blood draw, his AST might bump up.
Or if he has a mild viral illness, his ALT might bump up.
Exactly.
If you hang your entire clinical assessment on the ALT or AST, you might prematurely declare victory when the disease is quietly progressing underneath.
Which is terrifying.
Or conversely, you might falsely assume failure when the patient is actually improving metabolically.
So what should we be looking at instead?
You should be looking at the broader metabolic picture. Is his A1C improving? Are his triglycerides down? Has his waist circumference decreased?
The structural metabolic changes.
Yes, those are far better indicators of lifestyle success than an isolated ALT lab draw.
What about the assumptions we make regarding drug efficacy? Because I think we overestimate what these pills can do.
That is the second major pitfall. Clinicians must not assume that pharmacologic therapy reverses advanced fibrosis or cirrhosis in NAFL patients.
We can't undo the architectural damage with a prescription.
No, we do not currently have a magic pill that erases years of architectural scarring.
Right.
Furthermore, as we discussed with the Pivens trial, we must not apply evidence from more severe fatty liver conditions like NASH or from broader generalized fatty liver disease populations and map it onto this specific, milder NAL cohort.
It's an apples to oranges comparison.
Exactly. The populations are different, the underlying pathophysiology at that stage is different, and the risks are different.
We also shouldn't be jumping the gun, right? If a patient comes in on day one with an elevated ALT and fatty liver on an ultrasound, we aren't immediately reaching for the prescription pad then either.
Never. Medication should never be initiated before an adequate, documented trial of lifestyle intervention has been fully completed.
And what's the time frame on that?
6 months is the absolute minimum benchmark. You have to give the liver time to clear the lipid droplets once the metabolic index has been reduced. That takes time.
It's not an overnight fix.
And we certainly should not initiate pharmacologic therapy based on inconsistent or low quality of life data, hoping a pill will just make them feel better generically.
That's a great point. Now, let's draw some hard exclusionary lines here to be absolutely crystal clear. Who does this specific clinical framework, the lifestyle default rule, not apply to?
There are strict exclusions that every clinician must be aware of. Under no circumstances should this evidence base be used to manage or indiscriminately prescribe medications to pediatric patients, pregnant individuals, or patients with alcoholic liver disease.
Because the drivers of the disease are completely different in those cohorts.
Completely different. The physiology of a pediatric patient with NAFLD is deeply tied to development and genetics. It's a different beast entirely.
And pregnancy introduces an entirely different hormonal and metabolic state.
Right. And alcoholic liver disease is driven by direct ethanol toxicity, not primarily insulin resistance.
The toxic insult is different.
The risk profiles for those populations are entirely different, and this framework simply does not apply to them. You cannot manage them the same way you manage Mark.
So what does this all mean? If we distill this entire, highly nuanced discussion into a single definitive clinical takeaway for the practitioner listening right now who is about to walk into the exam room to see their version of Mark, it is this. For adults with NAFL and persistent abnormal liver enzymes after 6 months or more of lifestyle changes, continue lifestyle management by default.
Stay the course.
Do not chase the red numbers on the lab report with systemic medications. Only consider pharmacologic therapy if clinical progression, advanced fibrosis, comorbid type 2 diabetes, or informed patient preference strictly justify the deviation.
If we connect this to the bigger picture, this raises a profound professional question for all of us to carry forward.
Let's hear it.
If our current pharmacologic options primarily chase fluctuating surrogate markers while carrying real risks, like weight gain or stroke, without proven mortality benefits for this specific NAFL population, how should we as a medical community be redefining our concept of treatment success during our daily patient encounters?
Is a paradigm shift.
It is. Are we actually treating the patient's long-term health, or are we just treating our own anxiety about an abnormal lab report?
That is exactly the kind of question that should challenge us to be better clinicians tomorrow than we were today. We need to focus on metabolic health, not just isolated biochemistry. Thank you for taking the time to explore this complex clinical scenario with us and for your continued dedication to the health and well-being of your patients.
Thank you for joining us.